Good morning, everyone. Welcome to Day 11 of Acharya Rad Connect 2025, a premier online webinar series organized by Department of MIT AIAHS in association with Indian College of Radiological Technology. I, Nasrin, will be your host for today. It is my pleasure to introduce our esteemed speaker for today, Ms. Blossom Fernandes. Ma'am is currently a PhD scholar in neuroimaging and interventional radiology at prestigious Department of Psychiatry and ADBS Neuroimaging Center, NIMHANS, Bangalore, Karnataka. With her expertise in neuroimaging, she is at the forefront of research in the field of imaging techniques and psychiatry. She has more than a year of clinical experience as a technologist, making her highly skilled in various imaging modalities. Ma'am has attended numerous state and national conferences to stay ahead in her field and has presented her research at various national platforms. Her contributions to the field are also evident through her publications, including an article in the Acharya magazine on MR neurography, a groundbreaking area in neuroimaging. We are fortunate to have her with us today and we look forward to hearing her insights. Ma'am, over to you.
Thank you for the invite and for the lovely introduction. Okay, to begin with, my name is Blossom, and I'm a PhD student currently, but I'm also a JRF working for Center for Brain and Mind project in NIMHANS, Bangalore. Okay, so the topic that I've selected to talk about is advancements in neuroimaging techniques and analysis. So, given from my background and everything, I have 1 year experience of working in neuroimaging and analysis, and it has been quite an enriching journey so far. So, to begin with, I would want to say, first of all, this is a very vague presentation. Many of the things that are explained in this is a whole field in itself. So, it is very difficult to, accumulate everything at one point and present it for just 1 hour because it's definitely not possible. But in other words, I have tried to accumulate as much as I can. And again, much of my data I cannot really present because it's patient data. So my project is very strict about sharing data. Nonetheless, I've explained most of the techniques. So we'll see how it goes. And please feel free to ask any questions or any doubts if there are any. Okay. So to begin with, it's always a common question to start with what exactly does the topic mean and why is it so important? So to begin with, neuroimaging, first of all, is a very important topic, is a very important branch of radiology that helps to understand the structural function and the physiological working of the human brain. Along with all its other components, it also helps to understand and gives a support to neuroscience research and background. So many times what happens is that many brain disorders are not really known why they happen or what they happen. And if we don't know why it's happening, they are not able to treat the cause, correct? So neuroimaging is one such modality or one such field of imaging that is so vast, so advanced, and so has so much more to offer that it allows every kind of research and every kind of study that you can probably conduct to enhance your understanding of how the human brain works, what are the various things that are wrong with it, what are the various structural abnormalities that have. So neuroimaging is one very important and very interesting field that is my favorite. And of course, it really is much more advanced than it seems to be. So gone are the days when neuroimaging used to only exclusively be restricted to just CT or MRI or X-ray. So with the given advancements taking place every single day, it has undergone many transformative advancements. One minute, I'm sorry. Undergone many transformations. Enhanced our ability to study brain structure, function, and disorders. The most latest advancements, however, in neuroimaging have groundbreaking applications across neuroscience and even cognitive enhancement. So, am I still audible?
I think there's some disturbance,
Hello?
ma'am. Once a while it's cutting off. The audio is cutting off.
Audio is cutting off.
Yeah, now it's fine.
It's okay, right? Okay.
Yeah.
So what I was saying is, yeah. So I'm talking about neuroimaging advancements. So what has happened is many times there have been many bridges or many gaps in understanding why certain brain disorders take place or why certain neurological take place. So in order to understand that, neuroimaging comes into science because when you see exactly what is wrong inside the brain, you're able to go and pinpoint the brain is what is the problem. So all of these techniques, all of these advanced yeah, so moving on. There are, like I said, it's a very vague topic. It's a very vast topic. So mentioning and being able to tell everything about it is not going to be feasible in this given time. But I have tried to inculcate most of the topics and techniques that are usually included in neuroimaging advancements. Okay, so moving on. So the first thing that I want to talk about is functional MRI. This is something that I am working on and is also a very crucial part of neuroimaging. So functional MRI, as we all know, it is the most common core principle that it works on is Bolt signal, that is the blood oxygen level dependent signal. And most of the times, this is mostly important to understand and assess how exactly the patient is able to comprehend or rather is able to understand the kind of task that is given to them and the kind of brain activity that takes place when the patient is doing so. So, and again, like I said, applications are understanding rapid cognitive processes like memory formation, emotional regulation, how exactly which particular region or structure within the brain is responsible for that particular task. So, all of these things play a very crucial role, sorry, in understanding how exactly the human brain works, how exactly any dysfunction takes place in the brain when certain disorders occur. So, apart from that, a very crucial element of this is the resting state fMRI, wherein intrinsic brain networks are studied to understand disorders like Alzheimer's, schizophrenia, Parkinson's disease, etc. Now, one thing I would like to mention here is when we talk about resting state fMRI, what we usually ask the patient to do is just keep their eyes open and stay still and try not to think about anything. But it is very difficult for patients who have Alzheimer's, schizophrenia, PTSD, OCD, Parkinson's. All these patients, it's very difficult to, not think, not move. So when we perform such tasks, when we perform such techniques on such patients, we come to know that there are various regions within the brain that do not get activated, which would normally get activated in a healthy individual. Simultaneously, on that same note, there are also connectivity pathways that are created within the brain. Those connectivity pathways also tend to get hindered in such patients. Now, one such thing that I would like to mention here is the FST tract. Now, this is something that I'm working on, wherein we are seeing the frontostriatothalamic tract in the schizophrenia patients, which usually is affected, or so to say, the density or the intensity of that particular tract, which would ideally be pretty sturdy, fine in a healthy individual, is completely degenerated in a schizophrenia patient. Also, we're trying to assess the fact that if medications are given to such patients, is the tract health improving or is it able to regenerate itself? So, all these things can be assessed using only resting state fMRI and nothing else. Okay, so use of many advanced or maybe sophisticated task-based MRI sometimes is not even needed because resting state itself is so abundantly filled with knowledge. Okay, so also we can also integrate these MRI techniques to understand, integrating this functional MRI with something else, like for example, diffusion MRI or structural MRI or any other modality for that matter, CT, DSA. So when we do that, we get a much more wholesome idea of what exactly is wrong and which exact portion of the brain is wrong. So it gives you a much more better understanding of brain disorders. Okay, so moving on. Okay, so the advances that have taken place in functional MRI most importantly include first thing is a high resolution structural MRI, which enables submillimeter imaging of cortical structures, improving brain mapping accuracy. Now, if you'll remember or know that functional MRI images are always very grainy and noisy. So one major advancement that has taken place in this field is the fact that there is high resolution structural MRI generated. Am I still audible or have I gone? So yeah, I was saying, so we have high resolution structures. What does this mean is that we are able to assess various portions, tiny small portions of the brain within the resting state MRI. It's within the functional MRI itself. We don't really need to again register it onto a normal T1 weighted image and then see the structures. But within the functional MRI itself, we're able to see various small structures like the substantia nigra, then the caudate nucleus, all these things, globus pallidus, everything can be seen pretty well in the functional MRI itself. Apart from this, there is also other techniques like parallel imaging, like SENS, GRAPPA, which has increased temporal resolution even further because they accelerate data acquisition. So when we are taking data more faster, that we're able to capture much more images, much more faster, in a much more reduced time frame. So that further will enhance our understanding of how exactly certain regions in the brain work and certain regions in the brain get enhanced or more like highlighted when certain structure is stimulated. And then in simultaneous multi-slice imaging, what happens is that multiple brain slices can be acquired at a single time in a kind of like a rapid whole brain imaging. So this is again, we don't have this yet, but we're working on it. But we do have SENS, GRAPPA, and we do have ultrafast echoplanar imaging. So in ultrafast echoplanar imaging, what happens is that acquisition time is reduced and quality of the images are still quite maintained. So when this happens, what happens is we get a lot of quicker data. It's much more fast, it's much more efficient, and the resolution of it is also pretty good. So these are the simple basic advances that have taken place in functional MR. Now, again, like I said, we don't just acquire the images, but we also analyze them to achieve the information that we want to achieve from them. So there are many statistical tools and many neuroimaging software applications that are available online, and it's pretty free and it's very easy to use because they have a very detailed documentation on how exactly it is. So some of the few analysis tools I have mentioned here, but again, these are just four that I have worked on. But apart from this, there are many other tools that you can also work on and try out. So to name a few, for functional MRI, the first thing that we do is we pre-process any image that we get. We always have to pre-process the image. Okay, pre-processing would include simple things like removing like accounting for motion correction, if there has been any sort of graininess that we don't want. So removing all of that is important. All of these things can be done using the SPM software, that is the statistical parametric mapping, which again has another sub tool under it called CAT, that is computational anatomic toolbox. So this again can be used for various kinds of activities. Okay, it doesn't necessarily have to be just pre-processing. It can also be used for segmentation, normalization, all of these other tools. Other than that, we also have FSL, AFNI, and CON. Now, the most commonly used tool is FSL and AFNI. So it gives you real-time imaging. So AFNI is usually used for analysis of functional neuroimages, wherein for fMR specifically it's widely used actually for fMRI analysis, and it gives very good responses and very good analysis results. So I have a small video here showing you how exactly AFNI works, because this is something that I was working on and this is a part of my data set. So what you'll see here is this is a typical resting state fMRI image in sagittal. This is the same in eggshell. The timelines that you see here, the graphs, are the timelines, okay? How exactly does it work? What exactly has happened? So you'll see as you move along, the timelines will change and differ. So the center here, this portion, if you'll see, is where the graph is being measured for. The red dot, if you'll notice, is the time length or area where you are. Okay. So if you see as you move along the graph, you will see if there has been any motion in the patient. has there been any movement? So if you see, there has been the voxels, that particular voxel is being imaged, or rather is being shown over a period of time. Okay, I'll show you again. So what we are assessing here is, this is the time period for this particular voxel right here. Okay, should the patient move, or has the patient had any kind of a slight movement throughout the entire study, it will all be shown as a big major dip in the graph. Okay, these graphs are the time intensity graphs that we can see for each of these voxels. Okay, so as and when you move this, we can actually see in which voxel where what movement has occurred, what kind of image can that give. So simultaneously, this voxel, if placed into a CSF or if placed outside, will give you absolutely no graph per se. So this is how AFNI works. And mind you, this is not the only thing that it does. This also has many other functions. So I was just able to show you this and not much more, but we can also register and assess the, excuse me. So we're also able to assess the areas that have been intensified during the entire study and the areas that have not been intensified, which we hoped to be intensified but weren't intensified during the study. All of these things can also be done using AFNI. Okay, so coming to the next important and next most widely commonly used, that is diffusion MRI. So everyone knows what diffusion MRI is. Everyone knows what DTI is, I'm assuming, and everyone knows what DKI is. So again, like I said, the most commonly used technique in MR and its core principle includes to map white matter tracks by measuring water diffusion and isotropy. So, what exactly is the basic tool and outcome is that we are trying to see how exactly the white matter tracts that are generated inside the brain appear and look like. Now, it is said and it is shown that in many diseases and many conditions, these white matter tracts are affected or are degenerated due to whatever reason. Okay, so when we assess a patient using DTI, when we are seeing that certain things have certain disorders have a certain way of showing themselves, DTI helps us specifically in Parkinson's and traumatic brain injury to understand the extent of neuronal injury that has occurred within the brain. Okay, so this is one very important thing that DTI has helped us to do. Apart from this, it also helps in helping neurosurgeons to avoid critical white matter pathways during surgeries. Then it also reveals altered connectivity in conditions like depression, PTSD, and OCD, which helps identify biomarkers for treatment responses. So what happens is that we use certain biomarkers in imaging, which will help us to know that either elevation or decrease of that particular biomarker would show a significant disorder. Now, in schizophrenia, the study that I am working on, we are looking at two important biomarkers. One is a neuromelanin biomarker, and the second one is free water, which is an element of diffusion. So both of these biomarkers would help understand and assess exactly how well the schizophrenia patient is understanding or is responding to treatment or is not responding to treatment. So the kind of advances that have taken place in diffusion would be improved fiber tracking models that will help understand the neuronal pathways for surgical planning. Then detecting early stage Alzheimer's and Parkinson's by tracking neuronal integrity, and free water, like I mentioned about, is a new age biomarker which is used widely for assessing the intensity of neuroinflammation in brain age. Okay, so these are few of the biomarkers that this is just two I mentioned, but there are a lot more that are being used simultaneously for various other disorders and diseases. So yeah, coming to the analysis part of it, we have we have various, again, like in fMRI, we also have diffusion analysis that we use. So in diffusion analysis, although one thing to be noted is that it is not the same as the functional MRI or structural MRI analysis. It is very much complicated, very very much in depth to be understood. And there is a lot of things that are going on. Okay, so we need to know that again, all of these tools are available online freely, and they have a very, very good documentation which will allow you to do it in detail, step by step, and it's very easy to use and very user friendly. So, FSL again is used here. FSL, by the way, stands for fMRIB Software Library, and this is a strong tool for cryptography and connectivity analysis. So, when we talk about connectivity, what exactly do I mean is the fact that we talk about the various regions of the brain that are interconnected. Okay, like I spoke about one particular tract called the FST, that is the frontotemporal tract, which is a very crucial tract seen in schizophrenia patients and PTSD patients or Parkinson's patients. So these are very important tracts. Apart from this, we also have the limbic tract, the thalamic tract, then the frontotemporal tract. All of these tracts play a crucial role in various brain functions whatsoever, and all of these, their healthy functioning and all can be assessed using all these tools. So MRTrix is also very ideal tool for advanced fiber tracking and cerebral deconvolution techniques. DSI Studio is a much more user-friendly tool that is specializes in connectome analysis and advanced ETI metrics. Apart from this, the most advanced and the most recently developed is NODI, that is a neurite orientation, dispersion, and density imaging. So this is much more advanced and a little bit complicated tool, but it is very, very efficient when giving out results because it is able to tell exactly the kind of neurite that we're assessing, whether it is an axonal neuron or whatever. Okay, so it provides a much more deeper insight into microstructural changes in white matter. DIPAR is also very commonly used, which has been there for a very long time, and usually used for metrics other than free water, fractional anisotropy, mean diffusivity, and radiant diffusivity. So usually DIPAR has been a helpful tool in assessing and clearing about the free water analysis. So that is another important tool. Again, all of these tools are just a few that I've mentioned. Apart from this, there are many more, and all of those can be assessed and looked out for. So coming to PET. PET is positron emission tomography, whose main principal function is to visualize metabolic processes by detecting gamma rays emitted by a radio tracer. So its common applications include Alzheimer's disease, wherein it is used to detect amyloid plaque buildup using fiber tracers like florbetapir. Sorry, Parkinson's disease tracks dopamine activity with F2 PET. Then it also detects areas of inflammation, particularly in chronic conditions like Alzheimer's, dementia. Depression and schizophrenia, it shows the neurotransmitter imbalances. That is how the dopamine function has been going on within the brain. Advances that have taken place within this particular modality is one thing is tau PET is now commonly being used, wherein the protein called tau, whose accumulation is mostly seen in dementia, is what is mapped and noted. So this is again a very much advanced technique, which is not yet here. We're trying to get it here in India, but it's not here yet. Then fMRI is also a very important tool, which is the modality is here in NIMHANS and is used widely. It has amazing soft tissue contrast, and the registration of the PET on the MR images is also very good. Another advancement is the time of flight reconstruction, which enhances image quality by leveraging photon arrival timing. This again helps very much make sure that there is no loss of photons when the emission takes place. So coming to amyloid PET, which is again a very frequently used radio tracer in Alzheimer's diagnosis. Then in epilepsy also it helps identify the seizure foci by detecting abnormal metabolic patterns. Again, this is not commonly used, but this is something that is done in research, wherein understanding exactly where the seizure foci exists, why it exists, and how exactly kind of radio tracer that can be used to study that is also something that is still being researched on. Okay, So coming to analysis, now under analysis also this has a much detailed and much more complicated analysis what I have mentioned here. But again, I have not worked in PET per se, but the basic things that we do in this are the pre-processing steps, the quantitative analysis, the kinetic modeling, and parametric imaging. So in post-processing step, the first thing that is done is attenuation correction, motion correction, and image registration. Then in quantitative analysis, the most important things that are measured is the standard take value, kinetic modeling, and parametric imaging. Okay, so standard uptake value usually measures tracer concentration in specific regions, and kinetic modeling captures the dynamic processes like glucose uptake or neurotransmitter release. Then parametric imaging generates voxel-wise maps for improved visualization of metabolic rates. So all of these analysis tools and more, by the way, this is not just it. There's a lot more that is being done along with these tools, but these are the basic things that is done in any PET image that you get. Okay, so moving on to the other advanced techniques that we have. So another very interesting and very more like a diagnostic and therapeutic study is transcranial electric stimulation, which is also called transcranial direct current stimulation. Right. So what happens in this is that it delivers a low intensity direct current to one particular structure in the brain. So it could either be, usually they choose the vertex, okay, the right to the vertex or the left to the vertex, that depends. So am I audible?
Yes, ma'am.
Okay. Yeah. So like I was talking, sorry. So there are electrodes that are being used. Okay, the basic functioning is kind of given here. We have an anode or cathode, a battery powered current regulator, and a control software for blinded protocols. Okay, so the anodal stimulation depolarizes the neurons, increasing increasing excitability, while the cathodal stimulation hyperpolarizes them, decreasing the activity. So how exactly and for who exactly is this thing helpful for? So most importantly, I have actually seen this, it has helped schizophrenia patients. So schizophrenia is something known as positive symptoms and negative symptoms. Negative symptoms are symptoms which include patients who have low social impact. They do not have a social life. They have hallucinations. They have voices that they can hear, both visual and auditory hallucinations. And apart from that, they also have a low lack of empathy on social response. So this, when used in schizophrenia patient, has drastically, along with antipsychotics, of course, has drastically helped reduce these symptoms in these patients. Apart from that, it has also helped in neuropathic pain and post-stroke rehabilitation because the various neurons in that particular structure or in that brain region are what are excited and de-excited to make sure that the impact that it usually used to give through pain is reduced. This is a much more advanced technique and is commonly used here in NIMHANS for various patients. And yes, it's a little painful if done, but it gives really formidable results and it has really good, almost zero to no side effects. So the current is always monitored by the giving physician, and it is always made sure that the scalp is cleaned properly at that particular region, and then only the electrodes are placed. So if there's any dandruff or anything, then the current will not be passed through it. So it again, like I said, the most common use of this particular technique is in reducing any kind of pain, if there should be any, and of course in post-stroke rehabilitation. Another advanced technique is the brain-computer interface, which uses sensors like the EEG headsets, the electrocorticography, or implanted electrodes to measure brain activity. Now, it has three things. It has a processor, it has an output device, and it has a prosthetic that is used. Okay, so the processor usually it has the sensor, the processor, and the output device. So the sensor usually is the EEG headsets that we have. Okay, it's kind of placed here. It's placed in any region of the brain that is of interest. And then it has a processor, the algorithm, which will tell exactly what what the signal is supposed to do, or the command that is to be given to that particular signal. And then the output device is a prosthetic, that is either a robotic arm, wheelchair, or any software application. So how exactly is this used? So this most importantly helps patients in ALS, spinal cord injury, or stroke. ALS is amyotrophic lateral sclerosis. Now, what happens in this is that patients tend to lose communication or mobility within their any limbs. So, such devices or such techniques can really help regain that, and it's really state of the art technique that is used mostly in rehabilitation rather than in medical purposes. Also, research wise, when we want to study, we can actually teach more to say, because this is something that can be monitored and modulated by us. So the various tools which are there, various techniques, various softwares which are there can actually teach that particular structure, that particular region back, the neurofeedback as we call it, is it increases the intensity of that region which has been affected due to anything, due to a brain region or due to any brain disorder, whatever. That particular area can then be restored its regular functions by teaching it to do so. Okay, so this is another very cool and very important technique that has really helped a lot of people in understanding and coming back to normal life in a normal form. So another technique that is used here in NIMHANS is the magnetoencephalography. This is pretty much exactly the same kind of like EEG. So sorry. This is pretty much the same like EEG, but in EEG we use electroencephalography. Here we use magnetic field. Okay. So the most common technique that is used here is that it measures the magnetic fields that are produced by the neural activity in the brain. So we know that when neurons fire, they create tiny magnetic fields due to intracellular currents. So we use this superconductor interface devices, which are called SWIDs, which are highly sensitive to the magnetic fields. Then, the most important area where this place is used in is epilepsy, brain tumor surgery, and neurodegenerative disorders. So, it localizes seizure activity to guide surgery for drug-resistant epilepsy. And in brain tumor surgeries, it identifies functional areas. Examples are language, motor to minimize post-surgical impairments. So, in neurodegenerative disorders, it tracks the brain function challenge it changes in Alzheimer's and in Parkinson's disease. So, this is how the setup looks like. This is how exactly the setup looks like. And the whole idea is that it has the various sources of magnetic fields that are being present around the neuron, which are then collected, or rather, it is basically synthesized by the SQUIDs, that is the superconducting quantum interference devices. Then the detection device will measure those particular small, tiny magnetic fields and then give them as a pattern in the image. Okay, this again has much more further advanced understanding and analysis that goes into play. And the images generated are pretty much similar to EEG, but again, these can be correlated or co-registered onto another MR image to get exactly the region that has been hindered. Okay, so these are a few techniques that I had. I just wanted to give a take-home message saying that there are a lot of advancements taking place by the day. There are a lot of new things coming up, literally by the day. The most important thing we need to understand is that there is a difference between acquisition of images and what are we doing with the acquired images. The advances taking place usually with respect to enhancing our way of, or rather, our various techniques of acquisition. Like apart from this, there is something known as GSM in MRI. There is something known as T1 row mapping in MRI. All of these things are much more advanced techniques of acquisition, which will help us understand how exactly the structures or various structures within the brain function or have been affected due to a particular disease. Now, acquiring them is not enough, but we also need to analyze them and understand what is the image actually trying to tell us. We might have a simple T1 image also for that matter. That is more than enough to give you a lot of information that you need. A simple T1 which can tell you the exact volume of the pituitary gland. It can also tell you the length and size of the caudate nucleus. It can tell you a lot of things. So understanding that a particular image in imaging has so much more to offer than just the way it looks. So it's crucial to know and understand how to use these various tools that I've spoken about and how exactly to, you know, better understand our better enhance our understanding of how exactly the brain works and how exactly various brain disorders take place. So I'd be happy to address any questions if there are now.
If anyone has any questions or doubts regarding the topic, ma'am can answer it for you. You can post your questions in the chat box.
I know it's a very vague topic and it has also subtopics for upcoming sessions of yours, but again, this is very brief. Am I audible?
Yes, ma'am.
Okay, so DW and ADC is applicable. Yes, of course, in stroke patients, DW and ADC is very much applicable, and it is commonly used, in fact, to differentiate whether whether the whether the patient has undergone stroke acutely or chronically. And DWI and ADC are actually the same thing, just two sides of the same coin. Diffusion weighted imaging and apparent diffusion coefficient is pretty much the same. But only thing is, it's the difference. Can you repeat the most advanced techniques for future? Advanced techniques. Everything is advanced, nothing is not advanced. But yeah, so the most advanced technique so far that has been done or that is being studied is we're assessing brain aging, right? From children till the patients are being followed up all the way to adulthood and old age. So that is one thing. Another thing is there is also study going on in America, Boston, if I'm not wrong, wherein they assess patients who are in terminal stages or who are in their basically on their deathbed to see how exactly the brain responds to when the patient is actually being taken off uh, ALS support, BLS support. When the patient is taken off life support, they exactly are able to assess when and how the brain functioning stops. So that is something that's very interesting and very intriguing to know that the brain will actually stop functioning exactly at this particular time, and this was the last neuronal uh, intensity that was left off when the brain stopped working. Anything else?
We will wait for 1 more minute for any other questions or doubts.
Sure. Okay, there is a question here, which is best to identify pathologies, T1 or T2 weighted? Okay, so I don't know about, I don't know how. Okay, so basically, we were always told, right from the time we were in bachelor's, that T1 weighted image is always considered as the anatomic image. It is exactly how your brain is placed before in front of you as an image. Okay, T1 always is an anatomic image. T2 is what we use for pathological images or disorders because that is the exact opposite of T1. So in a T2 image, what happens is that any kind of a brain disorder, a brain lesion, or a brain degeneration, or whatever is best seen in a T2 weighted image. But again, for diagnosing any kind of a pathology, it's not sufficient to have just a T1 and just a T2. We will need a much more advanced study to do that. It could be either diffusion would be needed to better understand the study. Then we would also require various kinds of other imaging techniques like SWI, FLAIR. So identifying it basically depends on what pathology you're seeing. Because sometimes if it is any cystic pathology, I think it will be better seen on T2 or FLAIR image. Again, depends on the pathology. What does minimum direction encoding you mean for DTI? Okay, so direction encoding, the minimum would be needed would be 6. So the most you would be able to draw out fiber tracks with it, which are very fluent or accurate. But minimum with minimum coding of 6 directions, I think should give you a good enough DTI. But we use at least of 64 direction. So that's the setting that we have in our softwares, and it gives very good tractography results along with connectivity results. For what all purposes TOF is applicable? Okay, so there is TOF that is used in MRI also. There is TOF that is used in PET also. So I don't really follow what your question is directed to us. If it is PET related or MRI related, because if it's an MRI, then it's related to MRI contrast. But if it's in PET, then it's with respect to time of flight, wherein we are assessing how quickly or how accurately we're able to catch the emitted positrons that are being emitted. MEG is the advancement of EEG. I wouldn't call it advanced. You can say it's an advancement, but it has been there for a very long time. It's not, how do I say this? This is not something that just came up 2-3 years back. MEG has been there much, like even I think much after EEG, MEG had come along, but it's been a while since it's been here, and it is commonly used, in fact, for most of the studies in patients here. Again, mostly to assess patients who have ALS or any other neurological conditions. MEG is the area of choice. In case of seizures, EEG is your modality of choice. Can you explain about why we changed B value and how the B value changed in post-processing? You can change why we change B values. Okay, first thing you need to understand what does B value mean. B value basically is the gradient strength that we are applying. So in diffusion, what we are doing is we're applying extra gradients apart from what is already there. So B value basically is the given value to the gradient strength of the gradient that is applied the particular time of imaging. So we have B0, we have B500, B1000, B1500, B2000. So it depends on what exactly you're imaging, how advanced is your modality, and how many B values you're able to change. So our system or passes a 3 Tesla Phillips system. So we have We have B values up to 2000, and we also have B values up to 2500. So how B value are changed in post processing. So in post processing, we don't change the B value because it is already there set, and that is how the image has been acquired in all of those B values. So we acquire those B values and then the image those various B values. What happens is when we, like, for instance, I want to assess my numbers, I want to see how good traffic becomes. So the matter tracks and the better will be the connectivity. So higher B value gradients are always preferred over lower B value gradients. What is the role of epilepsy in MRI? You mean what is the role of MRI in epilepsy? Because epilepsy is a brain disease. MRI is very crucial in epilepsy because we need to understand and know that see, it's not a disease that is going to show structurally, like, one particular region is affected and that region is showing as a degenerated or a dysfunctional region in MRI. It's not going to be that obvious. Sometimes epilepsy is unknown. The area or the foci of the epilepsy is not known. So MRI is very useful when it comes to terms like diffusion, like so much to understand where exactly the foci of the seizure exist. So when I say foci, I mean the main center or the area where seizure is originating from. So that exact region can be targeted to either surgically remove it or to stimulate it so that the seizure doesn't occur. So MR can, various sequences in MR can be used, but apart from that, I think, a much better modality would be EEG to understand the various curves and the various waves from where exactly the seizure profile is emanating. MRI has a very significant role and has always been used in terms of epilepsy, but it's never used when the patient is going through the epilepsy. It's always used after a certain treatment has been given to see if there's any structural deformity. If not, then we have to look for other alternative methods. Usually changes after the scan is done. I don't follow. B value change after the scan is done while in post processing. That does not change. That is just the same B value images that you're seeing. It's not changing. You're seeing one B value and you're seeing the first B value in B0. Then you're seeing the next image in B500, the next image in B1000. It's not changing. You can select what B value you want to see it in. It depends. See, you can set in your system how many B values you want your system to acquire. Okay. You can either set it to B1500, you can set it to B2000, but depends on how many B values your system is offering you. For us, our 3 Tesla system is offering us about B values up to 3000. So we can choose. Okay, but accordingly, you have to also address and know that when you're playing around with MR parameters, there's always something cut off. So your time will increase. You have to make sure of that. Then there will be a lot of table movement and noise for the patient. So you have to address all of those things before you can make any changes like this. But what I think you're talking about is that post processing, what you are seeing is the various images, B values, and the ADC map that is generated in a regular diffusion image. Anything else? Anything more?
It seems like there are no more questions. Thank
Okay.
you so much, ma'am, for taking the session today on neuroimaging techniques. I'm sure our participants were able to make use of this session in understanding the complexity of neuroimaging. Before we conclude, let me brief the participants about the next speaker for Monday. We shall have with us Mr. S. Dinesh, Assistant Professor of Department of Medical Imaging Technology, the Oxford Medical College Hospital and Research Center, Bangalore, Karnataka, who shall be speaking on MR-guided focus ultrasound for essential tremors. Once again, our sincere thanks to our distinguished speaker, Ms. Blossom Fernandes, for sharing such valuable insights to us, and to all the participants for their active engagement today. We hope that you found the session both informative and useful. We look forward to welcoming you again tomorrow for another enriching session. See you all tomorrow at 11 a.m. Until then, take care, stay safe, and have a wonderful day ahead.
Thank you.
Thank you, ma'am.
Thank you.